Good morning, everyone. It's so nice to be back in person, and we welcome you to our session for Pulmonary Pourri. My name is Danielle Getz. I'm CF Center Director at the University of Buffalo, and I wanted to introduce my co-chair.
Good morning, everyone, and thanks for the organizers for inviting me. I'm Marco Zampoli, a pediatric pulmonologist from Cape Town, South Africa, and we look forward to the session.
So we chose some pulmonary abstracts that we felt represented a diverse group of, and there was some concentrating on pulmonary exacerbations, one on smoke exposure and the modulator era, and then one on early onset lung disease. So our first talk is from Leslie Wong, who's a genetic counselor and medical student at the University of Wisconsin School of Medicine and Public Health, and she'll be presenting on defining and identifying CF early onset lung disease with cumulative clinical characteristics in the first 3 years of life. Welcome, Leslie.
Good morning, everyone. Thank you so much for the opportunity to speak today and present on our project defining and identifying CF early onset lung disease, or the CFELD scoring system, with cumulative clinical characteristics in the first 3 years of life. So my talk today will have two parts, where the first part will be describing the development of the CFELD scoring system, which was recently published in Pediatric Pulmonology in October. And then the second half will be the new application of the CFELD scoring system on the impact of intrinsic and extrinsic risk factors in early onset CF lung disease. I have no conflicts of interest to disclose. So to start with a little background, we know that early development of lung disease, which is defined as during the first 3 years of life, correlates with its progression in children with CF. And we know that there's significant heterogeneity in the onset and progression of CF lung disease. Very little attention has been given to the timing and determinants of early onset CF lung disease, or to the interplay of intrinsic or genetic and extrinsic or environmental risk factors in very young children that potentially determine prognosis as they age. We were able to address this gap in knowledge in association with the first project, which I'll describe shortly. So our research aims were to establish a novel clinical scoring system to identify and quantify the severity of CF early onset lung disease, and I'll use CFELD to describe this system throughout this presentation in young children with CF. To test the hypothesis that CFELD severity can be explained by a combination of CFTR genotype, non-CFTR genetic variants, and extrinsic risk factors, and to prospectively investigate the effect of intrinsic and extrinsic determinants on CFELD outcomes in the first 3 years of life. So our study population was in association with the first study, which is a multi-center longitudinal prospective study initiated in 2012 and initially enrolled 183 infants. You can see here are the 6 CF centers included in the study, which were carefully selected based on their strong newborn screening and genotyping programs. 145 of the infants were followed to 3 years of age, and we utilized pulmonary data collected to develop the novel CFELD scoring system. 104 of the subjects agreed to participate in whole genome sequencing, which is about 70% of the cohort. And then each subject's genomic data was then used to calculate a polygenic risk score, or PRS, for lung disease. We also collected socio-environmental data from parent questionnaires, and because we also had the whole genome sequencing data, we were able to comprehensively investigate both intrinsic factors, such as the polygenic risk score, as well as extrinsic factors like socioeconomic status. So next I'll talk a little bit about how the polygenic risk score is calculated. So the PRS score is based on genome-wide association studies, or GWAS studies, based on lung disease. So this figure is from a UK Biobank study in 2019, which was a GWAS analysis of FEV1 values to identify variants associated with lung function, and overall included more than 400,000 individuals. So the figure is showing some of the genetic variants or signals that they reported and how they are associated with lung function. So for example, the variants in red were associated with lower PFT values or FEV1 values, and the variants in blue were associated with higher PFT values. And so utilizing these observations, we were able to derive a polygenic risk score that reflects the net effect of many genetic variants on lung disease phenotype, as opposed to just looking at the effect of one single modifier or variant. So this is showing exactly how polygenic risk scores are calculated. So the PRS is the summation of the GWAS effect for each variant or single nucleotide polymorphism. In other words, it's the weighted sum of the number of risk alleles, which is based on the GWAS data. PRS methods have been used in other diseases, such as cancer and cardiovascular disease, but has not been used to assess CF lung disease before. For our study, we utilized more than 33,000 SNPs from the UK Biobank database to calculate polygenic risk scores. And then these raw PRS scores were then converted into Z-scores. In addition to the PRS data, we also collected socioeconomic status and environmental data through a parent questionnaire, which was collected in infancy and then annually thereafter. Some examples of some questions include each parent or guardian's highest educational level, household income, siblings with CF, daycare attendance and how many hours, as well as passive exposure to smoke in the home. We utilize multiple statistical methods, including analysis of variance, median test, chi-square and Fisher's exact test, as well as a logistic regression, which was a multivariate analysis. So next I'll move on to the results. And this first part of the results is describing the development of the Seefeld system, which was recently published. And so I'll kind of go through the development of the characteristic clinical features in the Seefeld system, the evolution based on expert pediatric pulmonology input, as well as the distribution of the Seefeld scores in our cohort. So for the Seefeld system, it was based on 8 characteristic features of CF lung disease, which you can see here. And they encompass the major manifestations of pulmonary exacerbations, positive cultures for Pseudomonas and Staph aureus, other respiratory-related hospitalizations, as well as a chronic cough score, which was previously validated from the Wisconsin randomized control trial of CF newborn screening. For each of these criteria, we then assigned a points system where the sum of the points constituted the overall Seefeld score. For the chronic cough score, this was represented by calculating a cumulative cough score in the first 3 years of life based on parent-reported cough scores at 4 different levels, 1, 2, 3, and 4. So for example, a cumulative cough score of 1.75 indicates that parents reported more than an occasional cough at 75% of their visits in the first 3 years of life. So this is showing the Seefeld score distribution in our cohort. So on the y-axis is the Seefeld scores from 0 to 12. And then for each of the scores, you can see the horizontal stacked bars are each of the 8 measures in the Seefeld system. So for example, how many patients had a pulmonary exacerbation hospitalization, how many had a Pseudomonas hospitalization, and so on. Based on the Seefeld scores, we then classified patients into one of these 5 severity categories. And the distribution in our cohort is shown here in the pie chart. We had almost half of the cohort in the moderate and severe categories, which indicated an early onset phenotype. And the other half were either asymptomatic, minimal, or mild. And this really just kind of highlights the heterogeneity of the onset and progression of CF lung disease, even at such an early age in the first 3 years of life. So establishing the Seefeld system allowed us to move forward with the new application of this system for evaluating both intrinsic and extrinsic risk factors on early onset lung disease. So I'll go through the CFTR genotype impact based on pancreatic insufficient and sufficient variant classification, aggregated genetic modifiers by the polygenic risk score, and the impact of socioeconomic status and environmental factors. So we first performed a univariate analysis to evaluate the impact of CFTR genotype on Seefeld severity. So instead of using the McCone classification system for CFTR genotype, which is based on molecular mechanism, we applied a pancreatic phenotype-based system to classify our genotypes. So you can see here are the 4 different classification categories that we had: homozygous F508del, F508del with another pancreatic insufficient variant, 2 non-F508del pancreatic insufficient variants, and then all the way on the right is having one pancreatic sufficient variant. And so what we found is that we saw a much higher prevalence of asymptomatic and minimal Seefeld scores in the patients who had one pancreatic sufficient variant compared to the other three categories. The second factor that we evaluated was the impact of the polygenic risk score. And just as a brief reminder, the PRS is calculated as the summation of the GWAS effect for each of the variants or SNPs. So the raw PRS scores were then converted to Z-scores, and then we classified them into three different categories: low, intermediate, and high. And so we found that there was a significantly higher prevalence of the severe and moderate Seefeld scores in patients who had low PRS Z-scores compared to high PRS Z-scores. We also evaluated many different socioeconomic status factors, but out of all of them, the only significant predictor was maternal education, where the mother's education at or above community college was significantly associated with milder Seefeld scores. The second SES factor that came close to statistical significance was the type of health insurance coverage, where being covered by Medicaid or another public health insurance was associated with more severe Seefeld scores. We also observed that having a stable two-parent home in the first 3 years of life was significantly associated with many of the other SES factors, such as parental education, household income, and type of health insurance coverage. And so because of this, we derived a composite SES indicator, which we called high and stable SES. And the criteria are the mother's education at or above community college, not being on Medicaid, and having a stable two-parent home in the first 3 years of life. And you can see that for our cohort, being in this high and stable SES category was associated with milder Seefeld scores. And so this composite SES indicator became important as we went forward with our multivariate analyses. We also looked at 4 different environmental factors on the impact of Seefeld severity: having CF siblings, having dogs at home, passive exposure to smoke, as well as daycare attendance. And only daycare attendance was found to be a significant predictor of Seefeld severity, where attending for 20 or more hours per week was associated with more severe Seefeld scores. Our main goal was to evaluate genetic factors as well as socioeconomic factors, in addition to the traditional CF clinical care factors and how they impacted Seefeld outcomes. So our final analysis was a multivariate regression analysis, which is shown here, for each of these factors in order to evaluate them in the presence of all of the other variables. So you can also see the odds ratio here, which is reflecting the risk of more severe Seefeld scores for each of these factors. And so we found that both of the genetic factors, CFTR genotype and PRS Z-score, were significant predictors. For CFTR genotype, we found that having F508del or pancreatic insufficient variant in both alleles was associated with an increased risk of a more severe Seefeld score. And we found something similar for low PRS Z-scores as well. Having a low PRS Z-score was also associated with an increased risk of a more severe Seefeld score. We also found that the high and stable SES category was a significant predictor as well. As you can see in the middle, being in this category was associated with milder Seefeld scores. And then also shown here is the daycare attendance, where attending for more than 20 hours per week was associated with more severe Seefeld scores as well. So overall, we utilized readily available clinical information reflecting the most characteristic features of CF lung disease in order to establish this novel Seefeld scoring system. And we showed for the first time that polygenic risk score is a significant predictor of the early onset lung disease phenotype, especially in young children with CF. And in our cohort, interestingly, maternal education was the single most significant SES predictor for early onset CF lung disease in the first 3 years of life. While we weren't really surprised that maternal education was such an important factor, we were interested to see that the effects can be seen at such an early age, before the age of 3. Some potential limitations of the study include the methodology for constructing the Seefeld score, because the selection of the 8 measures was subjective and not entirely evidence-driven. Other limitations also include the methodology for calculating the polygenic risk score, since we're limited by our current genomic data, which is always evolving as new genetic variants and SNPs are discovered. and then also an underrepresentation of African American and Hispanic patients in our cohort. So in conclusion, CFELD is a novel scoring system that incorporates the most characteristic features of CF lung disease and allows identification of early onset lung disease phenotype. Using a polygenic risk score has the potential to be incorporated into clinical research and management of CF lung disease. And we feel that genetic, socioeconomic status, and environmental factors should be included in addition to CF care for risk prediction of early onset lung disease outcomes. And I wanted to end this talk with a sincere thank you to the participating families, the first study sites and investigators, and the CF Foundation for supporting this project.
Thank you, Ms. Wong, for your talk. I was just going to tell everyone if you wanted to stand up and ask a question. We don't have a microphone, but feel free. It's a small enough room, and I can repeat the question. Or if you're on the app, you can enter a question into the app under the Q&A on this session. I don't see any questions right now. One question I had, Ms. Wong, was how do you see this score moving forward in our maybe clinical use or further research?
Yeah, so I think that we really wanted to bring awareness, especially to the fact that we don't have kind of a definitive score for such an early age. We can't use pulmonary function testing for ages 0 to 3 to establish a lung disease phenotype in this age. And so because we know there are such characteristic features of CF lung disease as well, it seems to make sense that we could use a clinical scoring system like this to establish phenotypes at an earlier age than, for example, a pulmonary function test could show. So I think that'll definitely be important because we know that there's such heterogeneity in the progression of lung disease, and so having a system like this to categorize early onset lung disease, I think, will be very important.
I was just wondering also if could any objective measures such as preschool spirometry or lung clearance index or even other like CT scans that are done in some places be added to the factors that are evaluated?
That's a great question. So actually our next step is to start incorporating the chest CT imaging and kind of correlating that with CFELD scores to kind of validate the score as well. So that's kind of our next step for the project.
Great. Go ahead.
Yeah, I definitely think it would be appropriate to share it with them, especially if you kind of walk through each of the different measures and what we're looking at to construct the CFELD score, and how each of them are objective measures. We're looking at pulmonary exacerbations, which we know has a significant impact on CF progression of lung disease. So I think kind of providing some of that education, I think, will be really helpful for these families as they're kind of adjusting to maybe a new child with a complex disease.
Dr. Farrell.
Thank you. I just want to make a comment. To my knowledge, this is the first time whole genome sequencing has been applied to a cohort of children with cystic fibrosis. And I'm witnessing two things about this. First of all, we're really grateful to our site PIs for their willingness in 2017 to go forward with this. We didn't know how we would do in terms of parental consent, but we did very well. 90% of the parents approach specifically having whole genome sequencing done. Secondly, we believe this is the best way to study genetic modifiers for CF lung disease. This TRS score aggregates the genetic modifiers that are identified in QOS studies. And the aggregation of genetic modifiers seems to be more valuable than investigating a single genetic modifier. The third thing is, you may not believe this, but whole genome sequencing can now be done for $200 a time. $200 a time. So what does that tell you? It tells you it's going to be part of our practice institution.
Thank you. Go ahead.
You mentioned one of your limitations was the lack of Hispanic and African American. Is there thoughts to, and so most of the groups are northeastern part of the country, is there thoughts about expanding to like more of the southern states to get better variety of data?
Yeah, that's a great question. So in our cohort, we had about 9% non-white participants. And we know that in the literature, it can cite up to like 20% of CF patients who are non-white. So we did kind of make some special efforts in certain cities of the CF centers to kind of expand the recruitment to include more diverse areas, such as Chicago. But I think that's kind of definitely an ongoing thing. We want to keep recruiting minorities and non-white patients.
Thank you so much, Ms. Wong, and thank you for your comments, Dr. Farrell. And we're going to move on to our next presentation. Thank you so much. So I wanted to introduce Dr. Gabriella Oates, and she is an associate professor at the University of Alabama at Birmingham. So Dr. Oates, please welcome her, and she's going to talk about tobacco smoke exposure, reducing the clinical efficacy of ivacaftor.
Thank you. So I'll be talking about the extrinsic factors today. Thank you for having me. I have nothing to disclose related to this presentation. So, smoke exposure, not very popular topic in our community, however, very highly prevalent and yet extremely under-recognized issue in CF care. Approximately 30% of children with cystic fibrosis in the United States are exposed to second or third-hand smoke or passive smoke based on self-reports by their caregivers, and rates are similar among adults. And this is concerning because there is no risk-free level of exposure when it comes to smoke. For example, in households where there is a member of the household who is a smoker, even when there is a complete indoor smoking ban, so the person only smokes outdoors, children still have up to 7 times more nicotine than children in homes where there is no smoker whatsoever. So this is concerning because in addition to the general risks associated with smoke exposure, such as increased inflammatory markers and decreased lung function, there are specific risks for people with CF. So studies that have been done in the past with animal models show that smoke exposure reduces the functional expression of the CFTR gene. And other studies also show that smoke exposure inhibits the anion transport by the CFTR, leading to mucus stasis. In human studies with people who do not have CF, smoke exposure actually leads to acquired CFTR dysfunction. So these prior findings lead us to believe that smoke exposure may be diminishing the clinical efficacy of CFTR modulator drugs. And we saw first evidence of this in our analysis of CF Foundation patient registry data, where we reported that smoke exposure self-reported by caregivers pretty much eliminates the therapeutic benefit from tezacaftor, ivacaftor in adolescents with cystic fibrosis. And we also know that approximately a quarter of people with the G5Y1D mutation do not respond to ivacaftor, even if they have high adherence rates, which contribute to our hypothesis that possibly smoke exposure is a contributor to this lack of response. It's been problematic to do research on smoke exposure and CFTR modulators because we only typically have self-reported smoke exposure data, as also presented by the speaker before me. This is problematic because there is severe underreporting of exposure by self-reports. For example, in the CF Foundation patient registry, approximately 15% of people who reside with a smoker in their household, they say that they're not exposed, which really is not possible. They are exposed through third-hand smoke exposure or smoke residue left on hair, skin, clothes, objects, and house dust, etc. So when you compare self-reported data to biomarkers of smoke exposure, you see that in children below the age of 10, smoke exposure based on hair nicotine is almost 60%, not the 30% that we know of. There is also exposure from the environment, even if people do not reside with a smoker in their household. For example, in inner city, urban environments, up to 90% of adolescents are exposed to smoke based on biomarkers of smoke in urine or hair. So what we wanted to do is, move on to the next slide. Determine the effect of smoke exposure on response to ivacaftor using biomarkers and move away from the self-reported smoke exposure thing. So what we did is we used data in urine samples from participants in the GOAL observational study of ivacaftor, and they are ages 6 to 59. We measured smoke exposure before the ivacaftor initiation using mass spectrometry of urine and two biomarkers of exposure. The first one is the NNAL. It's a nicotine metabolite, which is highly specific to secondhand smoke exposure, so no active smoking. Exposure among non-smokers. And the second one that we were interested in is the 3-HPMA, which is a metabolite of acrolein. Acrolein is a toxic compound in the secondhand smoke. We are specifically interested in acrolein because prior studies in vitro and in vivo show that it affects CFTR gating and channel function. We use these two biomarkers in combination to assess levels of smoke exposure. People who were not exposed had 3-HPMA below the 50th percentile and NNAL below 10 picograms per milliliter, which is a cutoff established in the literature for secondhand or third-hand smoke exposure. And in contrast, those who were exposed in red, they had 3-HPMA values above the 75th percentile or NNAL above 10. In the group with values in the middle, we labeled as undetermined. We cannot say for sure whether they're exposed or not. We did compare both the undetermined and exposed group to our unexposed group, which was our reference category. In these slides, I will only present results comparing the exposed to the unexposed. There we go again. So we assessed one primary and two secondary outcomes. We were particularly interested in sweat chloride because it's a measure of CFTR function. It's as good as we can get right. But we also did measure secondary clinical outcomes such as lung function and respiratory quality of life or respiratory symptoms measured with the CFQR respiratory scale. So our sample included 142 individuals, ages 6 to 59 with a mean age of 21. I want to draw your attention to the fact that in this cohort, which is part of the first clinical trial of ivacaftor, 15% self-reported that they're exposed through second or third hand smoke exposure. There is somebody in their environment who is a smoker. And now see, based on our biomarkers of smoke exposure, what those exposure rates look like. We had 29% exposed based on biomarkers, 50% unexposed, and 21% we can't tell for sure. So we had significant results when it comes to our primary outcome, sweat chloride. This figure shows sweat chloride by smoke exposure status, where the unexposed participants are in blue and the exposed participants are in red. You can see that at baseline, before ivacaftor initiation, sweat chloride was very similar in both groups, around 102 millimoles per liter. And then after 6 months of treatment with ivacaftor, sweat chloride decreased by 59 millimoles in the unexposed group, down to 42. In the exposed group, it only increased by less than 45 points and remained fairly high at 58 points. So this shows that smoke exposure measured with urinary biomarkers is associated with 16 millimoles less improvement than sweat chloride. And these are statistically significant associations. We also saw those findings mirrored in our secondary outcomes. This figure shows lung function, mean lung function in the cohort at baseline and after 6 months of ivacaftor treatment, where the unexposed are in blue, exposed are in red. There's a significant deficit at the baseline between the two groups, and it increases after 6 months of ivacaftor treatment. These are just bivariate associations. Similarly, in respiratory quality of life, significant deficits at baseline, which maintained a little bit increased at 6 months ivacaftor treatment by smoke exposure. Now, we also found that even after accounting for potential confounders with multiple regression, these associations remained statistically significant. This table shows ordinary square multiple regression and demonstrates that controlling for age and baseline characteristics, including clinical characteristics and baseline values, smoke exposure is associated with 4.5% less improvement in lung function and 6.8 points less improvement in respiratory symptoms. These results are not only statistically significant, they are clinically significant. You can tell that for a fact for lung function. When it comes to CFQR respiratory, the minimal clinically important difference is 4 points for stable FEV1, and here we are at almost 7. So these results made possible for us to conclude that exposure to smoke in the environment limits the clinical efficacy of ivacaftor, quantified either by sweat chloride, FEV1, or respiratory quality of life. So what we're about to start doing as soon as this conference is over is assess the effect of smoke exposure on response to Trikafta using self-reported data from the CF Foundation Patient Registry, as well as biomarkers using hair nicotine that we have collected from children. Now, it is also important to include smoking cessation and CF care because smoke exposure is one of the very, very few modifiable risk factors in this disease. There are not many, and this is one of them. And we can use this sort of interventions to optimize the therapeutic benefit of highly effective CFTR modulators. And if you think that this is unachievable too time-consuming, can't do in clinical practice, there's no time. I want to take just 1 minute of your time and show you one more slide where we literally completed a pilot clinical trial for this in clinical practice, and it's hugely successful. So we piloted CCF, which is a clinical effort against smoke exposure in CF. It's a pilot intervention to test precisely the feasibility and acceptability and efficacy of smoking cessation interventions delivered as part of CF care, as part of the multidisciplinary team. We had intervention and control group that both received CF-specific smoking education, and an intervention group in addition received behavioral counseling and nicotine replacement therapy. So we developed our protocols, our educational and treatment resources. And look at this. We screened more than 240 caregivers. Previously documented smoke exposure was less than 20%. After in-depth, in detail assessment by the tobacco treatment specialist, we discovered that smoke exposure is actually 45%. We had 57% exposed children that were previously not documented because there is no smoker in the household and people don't really understand that their children are exposed. The intervention was highly efficacious because at 6 months we had sustained 18% quit rate, which is huge. Normally it's like around 2-3%. We had 78% reduced smoking rates with the mean cigarettes down from 14 to 9 per day, and we're currently analyzing our hair nicotine data. It was highly acceptable by participants and by the providers based on surveys, feasible, and we're currently analyzing our interview data to assess implementation barriers and see how can we upscale this to make it available to more centers, do a multi-site study, and gradually start to incorporate smoke exposure in CF care. I'd like to acknowledge my colleagues, Liz Baker, Vamshi Raju, Tom Harris, Steve Rowe, the care team at the Children's of Alabama Center, particularly our tobacco treatment specialist, Robin Gers, she's here, and the CF Foundation for use of patient registry and biorepository data. And I'll be happy to take any questions.
Thanks so much, Dr. Oates. I thought that was really interesting because we all know like smoking is bad, but taking that step forward, that's an intervention that seems to be working. There was a question about, are there any data on the effects of vaping versus combustible tobacco on CFTR function or clinical symptoms in exposed patients?
Great question. Thank you for asking, whoever you were. Please attend the session this afternoon by Dr. Kyle Blyton, a fellow in our center, who is presenting data on vaping. Yes, there is a difference outside of CF. In CF, we don't know. It's something we need to find out. Acrolein, for example, which is very harmful based on our data, is one of the main components in vapor. So we can hypothesize that it's equally or nearly equally harmful, but we don't know yet. Dr. Blyton will have some data this afternoon.
Great, go ahead.
That's a great question. As you know, pediatricians are not comfortable prescribing nicotine replacement therapy, pharmacotherapy to adults. So if it were pharmacotherapy, any sort of pill, we would refer to their primary care physician. If it was other type of NRT, gum, lozenge, patch, etc., we prescribe. Correct?
I was wondering, has the tobacco treatment specialist been used in like COPD or other diseases? Yep.
That's a great question. I don't know. I
'Cause it
know
seems
the
like a good
tobacco.
idea.
Oh, actually, I do. In our lung health center on the adult side, they use a tobacco treatment
Mm-hmm.
specialist. I don't know in detail how they use them, but we trained our own, and she's the best.
Yeah. Do you think that there'll be any utility to using these urinary biomarkers in like the CF registry? Since we know, like that was one of the most remarkable things that, I mean, we know underreporting occurs, but just to be more accurate in that regard?
So the inexpensive urinary tests are for cotinine, which does not detect secondhand or third-hand smoke, so it's not sensitive enough. So that's not really an option. The ones that do detect very low levels of exposure tend to be very pricey. For now, I don't know if there will be a change in the future. Hair nicotine tends to be less expensive, but kind of tricky. It's a good question. We probably need to just do more research to find out, is there an acceptable method of catching this, at least occasionally, and putting it in the registry? I don't know. I don't have an answer.
Just last question. We were wondering if there's differences in adolescents or adults who actually smoke versus children who are just exposed in the levels or...
Yes. In the adult cohort in the GOLD study, there were active smokers for sure, at least a few. Clearly, based on both biomarkers, their levels were through the roof, consistent with active smoking. Not many, but I would say at least 3 in this cohort.
Can I final question? Are there any questions? Final questions? Yeah.
Oh yeah, actually we published a paper about this last year. Once the exposure is removed, there is an increase both in lung function, BMI, and reducing of pulmonary exacerbations and hospitalizations. Within 3 years after the exposure is removed, we had 17% less odds of exacerbations per year, with an additive effect each next year. And 2% in BMI, 2% in FEV1, and the benefit gradually increased. So yes, it's totally reversible.
Thanks. For final question from me, these biomarkers, how time sensitive are they to the exposure? Is it, are they long, do they hang around a long time, and was it only recent exposure?
That's a great question, because most of them capture a short-term exposure, and that's not good for us. If children are exposed occasionally, we need to know that. NNAL that we use, one of the reasons we used it is because it captures long-term exposure around 2 months up to 3 months, and we thought that's good enough. I don't know of a biomarker that captures exposure beyond this point.
Thank you very much.
Thank you so much, Dr. Oates.
I'd like to introduce our next speaker, which is Christina Montemeyer. She's Assistant Professor of Medicine at Johns Hopkins University. The title of her talk will be Sex-Based Differences in CF Pulmonary Exacerbations, Sub-Analysis of the STOP-2 Cohort.
Great, good morning, and thank you to Dr. Getz and to Dr. Zampoli for inviting me to speak today. And excited to share my work with you over the next 15 minutes or so. Is the microphone okay? Perfect, okay. No financial disclosures, and do appreciate the support from the CF Foundation for my current research. And I think it's well known now in the CF literature, specifically starting in the 1990s, researchers have shown that females with CF have worse clinical outcomes. This has been shown by Raksha Jain and colleagues that the rate of death in females has been more than twice that of males. D.B. Sanders, who I know will be talking to us next, has shown that female sex has been associated with failure to recover to baseline lung function after treatment with IV antibiotics. And then Dutch Van de Vanter and colleagues has shown that females are more likely to require retreatment within 30 days after initial pulmonary exacerbation treatment. And an early question that I had and my team worked on was really looking at sex differences in treatment patterns using the initial parent stop cohort, because my hypothesis was that if women were treated differently than men, that could explain some of the sex disparity that we were seeing. So we used the opportunity to use the observational cohort of STOP, which was a standardized treatment of pulmonary exacerbations, which was conducted between January 2014 and January 2015. We did show that female sex was associated with a 13% higher rate of IV antibiotic treatment days. Females had less symptomatic recovery at the end of IV therapy despite receiving similar exacerbation treatment. And overall, we found no evidence of a treatment disparity, so there was no difference in inpatient length of stay, number of IV antibiotics, antibiotic selection, or initiation of adjunctive therapies. Given that this was an observational study, we knew that that was an inherent limitation to that, our analysis from that. So what we sought to do was to utilize a standardized treatment of pulmonary exacerbations 2, our STOP-2 cohort, which some of you may be familiar with, because this was a randomized controlled clinical trial within CF for IV treatment and exacerbations. And this, our group was the first to look at this and analyze it specifically by sex. Over the next 2 slides, I'll briefly describe the study, but visit 1 here, IV antibiotics for an exacerbation were started, and that was up to the discretion of the prescribing physician or provider. Objectives that were obtained were FEV1, lung function, as well as CRIS scores. So CRIS score, that's a patient-reported outcome that ask about respiratory symptoms. The scores range from 0 to 100. 100 in this case would be bad, so something we wouldn't want our patients to score perfectly on. So that was obtained at visit 1. 7 to 10 days later after being on IVs was visit 2. And this was a randomization occurred, and again, lung function and CRIS scores were obtained. Predefined values were set, so if participants scored both increase in lung function by 8% and an improvement in overall CRIS scores by 11 points, were randomized to this early robust responder group and received either 10 or 14 days of IVs. If they did not meet these criteria, they were then randomized to the NERR, non-early robust responder group, and received either 14 or 21 days. And I'll just call your attention here to visit 3. Again, lung function and CRIS scores were obtained, and this was done for each participant 14 days after the end of IV therapy. The overall hypothesis from the STOP-2 investigators and the overall conclusions, they showed that 10 days was not inferior to 14 days for IV treatment, and 21 days was not superior to 14 days. So we used this data to go over for our study and look at our clinical outcomes. And aligning with the STOP-2 study, our primary outcome was absolute change in lung function. We also had 4 secondary outcomes, which included absolute change in CRIS scores, again, the respiratory symptom scores, absolute change in BMI, time to next exacerbation, as well as any adverse events. As far as participant demographics and clinical characteristics, I have some of the important ones up here. Overall, there were 982 adults with CF that were identified. You can see here it's a pretty even breakdown between sex, between males and females. And I will point your attention to this column here. Females were more likely to have had a pulmonary exacerbation treated with IV antibiotics in the prior year. And these 2 columns here are both baseline lung function as well as max lung function in the prior 12 months. Females had higher values for both. And then this last column right here is females were more likely to have been prescribed steroids. Some data that I don't have here, but I think probably many of you are asking what percentage of patients were on modulators at this time. And again, this was prior to widespread use, specifically of elexacaftor, tezacaftor, ivacaftor, but about 30% were on non-highly effective modulator therapy, and less than 7% of our participants were on highly effective modulator therapy. I'm just showing some raw data here, but overall, females had higher lung function but worse respiratory symptoms across the visits. So for this top column here are visit 1, 2, and 3. Females, you can see here, had overall higher lung function. And again, visit 1 was at enrollment, visit 2 was 70 days after IVs, and visit 3 was 14 days after IV therapy. And then just showing again raw numbers for the CRIS or respiratory symptom scores. The higher the score, the worse severity of the symptoms. And you can see across each study visit, women scored higher than men. So going to the analysis, we did linear regressions, both adjusted and unadjusted models. On the left here, I'm showing just some of the data. I'm showing the point estimates with the 95% confidence intervals. And on the right, for those that may want to see more of a visual representation, using a forest plot that Dutch Van de Venter helped with. So appreciate him for that comment and recommendation. And as far as unadjusted and adjusted, for the next few slides, I just want to point out now, the adjusted model was adjusted for STOP2 stratification variables, which included treatment location prior to randomization, acute systemic corticosteroid use, baseline lung function, and number of pulmonary exacerbations in the prior year. So we were looking at the mean difference in lung function change from visit 1 to visit 3 by sex, so any difference between females and males, and overall there was no difference in lung function improvement by sex. We did a similar analysis for our respiratory symptom score, again the point estimate with 95% confidence intervals and forest plot, and no overall difference in respiratory symptom improvement by sex. Our third variable that we looked at was BMI. And overall, we know how important BMI is for both quality of life, respiratory symptoms, as well as lung function and exacerbations. And we did find that overall, females did have less improvement in their BMI compared to males in both our unadjusted and adjusted models. And we also looked at time to next exacerbation treated with IV antibiotics. So we did hazard ratios for this, and you could see it was female sex was significant in both our unadjusted as well as adjusted model, and then showing a Kaplan-Meier curve here on the y-axis is days to next IV treated pulmonary exacerbation, and on the y-axis is a proportion of pulmonary exacerbation free, that's participants. So overall, females, again, were more likely to have shorter time to next pulmonary exacerbation. As far as adverse events go, I'm showing you the overall events, but we also did do this by group, so ERR as well as NERR groups, and overall we got similar data. There were no difference in the max severity of adverse events, as well as no difference in participants with any significant adverse events. So overall, for our conclusions, we did show that sex-related differences in pulmonary exacerbation presentation were there. Females did start with a higher lung function but worse respiratory symptoms compared to males. We found no sex difference in lung function or respiratory symptom improvement from enrollment to 14 days after IV treatment concluded. We did show that females had less improvement in BMI compared to males. And overall, female sex was associated with an increased risk of future IV-treated pulmonary exacerbations, which does support other literature in this area as well from other researchers. I think some limitations as well as some future directions to include was STOP2 was conducted, as I mentioned, prior to widespread use of ETI, so less than 7% of the STOP2 cohort was on highly effective modulator therapy. STOP2 did include adults, so anyone over 18, so these results may not be generalizable to the pediatric population. There hasn't been much data looking yet at sex difference response to CFTR modulators, but there's been some data looking at ivacaftor, but not for the other modulators at this time, so something that we want to work on. And then I think just another interaction that we didn't get to delve too much into in our analysis was, is there any interaction between sex and treatment site and or location? Because I know that the STOP investigators did look at treatment site and location in a sub-analysis paper as well, and any time spent in the hospital was associated with improved outcomes. So something else that we're also trying to follow up on as well. I'd like to just thank Natalie West, who's my primary mentor, as well as Kevin Soder, who's our biostatistician who was instrumental in the analysis. I'd like to thank all of the STOP investigators, as well as the members of the Sexual Health, Reproduction, and Gender Research Working Group who have been helpful with my research and specifically this analysis. I'm happy to take any questions.
Great. Thank you very much. It was an interesting presentation. We have some questions from the floor.
Hi, that was a really great talk. I was wondering, are there any menstrual cycle related effects known about pulmonary exacerbations? And if maybe the point at which a person is in their menstrual cycle, if that has an effect on how responsive they are to antibiotic treatment?
Yes, that's a great question, and there is some literature on that. There's a group, it's Tomatrol from Ireland, looking at that specifically, and during the menstrual cycle, there has been more association with increased exacerbations. And I think your question also lends to a second, probably follow-up question that many may be thinking is, what is the impact of oral contraceptives on pulmonary exacerbations? Because that was something looked at in their study as well. It was a small cohort and something that I'm trying to extend upon in my Schwachman group as well. But we actually wanted to look at these participants and whether or not we had that granularity of data. And while we have prior medications, we don't have specifically OCPs or exactly what type they were, and other contraceptive methods besides OCPs. But that was a great question. Yes, thank you.
Well, I have a question.
Yes.
How do you explain or how did you interpret the difference, the contrast between the higher lung function and contrasting worse symptoms in females and males?
Yes, so we thank you for that question. And we saw that in the analysis we did in our STOP cohort using the initial observational study. And there has been some research within CF and outside of CF that women do tend to score higher on respiratory symptom scores in general. So what that was one factor to consider. And we don't know how treatment may be affected by that. But we have seen that's been shown within the CF literature already. So how do we incorporate that is still a question we weren't quite sure what to do with, but just be mindful of.
Right. Perhaps the second question I have, what was the reason more women had steroids? And you said you did adjust for that, but is there a reason for that?
Not that we were thinking the same thing. I don't think I have an answer for that though. But things that we thought of were so patients with ABPA should have been excluded from the study. So I think we take that factor out. The question has become: did more women, were they classified with having asthma, and potentially that was why they were prescribed more steroids. So those were two things that we considered, but I don't have an exact explanation for that at this time.
All right. Do you have any further questions from the floor? No, I think, all right, thank you very much. And we'll move on.
Okay, next, I wanted to introduce Ms. Anna Faino, and she's a biostatistician at Seattle Children's Research Institute in Shoreline, Washington. And today she's going to present on polymicrobial infections and antibiotic treatment patterns for CF pulmonary exacerbations.
Great, thank you for that introduction. So today I'll be presenting results from a study looking at polymicrobial infections and antibiotic treatment patterns for children with CF pulmonary exacerbations. I have no relationships to disclose for this presentation. So for some background and introduction, pulmonary exacerbations, which I'll switch between saying exacerbation and PECs, they're an important source of morbidity among children with CF and are associated with reduced lung function, weight loss, and impaired quality of life. No data exists to guide antibiotic selection among people with CF that have respiratory cultures that are positive for multiple CF-related bacteria. We're calling those polymicrobial infections. In particular, we're interested in Pseudomonas aeruginosa, methicillin-resistant and methicillin-sensitive Staph aureus, H. flu, Stenotrophomonas, Burkholderia cepacia complex, as well as Achromobacter. Our study aims were first to describe the number of polymicrobial in hospital-treated exacerbations that are occurring, then to describe the proportion of polymicrobial exacerbations that are prescribed antibiotics that cover all of the bacteria detected, and then to determine clinical and demographic factors that are associated with complete antibiotic coverage. For our methods, we used a retrospective cohort studies. This is merging the CFF patient registry with the FIS database. We have the strength of the CFF patient registry with all of the patient information. We can merge that with the FIS database. We can get all of the hospital administrative data, in particular, day by day, which medications were prescribed. Our inclusion criteria were children aged 1 to 21 that had an in-hospital exacerbation from 2006 to 2019, with IV antibiotic use within 48 hours of admission, length of stay between 4 to 35 days, no prior exacerbation within 30 days, and then finally, no culture positivity for non-tuberculosis mycobacteria in the prior year. For antibiotic classifications, we utilize the Sanford Guide to determine a list of antibiotics that are considered effective against each of the CF-related bacteria, with the exception for Achromobacter, we used a separate reference. So for study definitions, we defined bacterial culture positivity based on cultures in the prior 12 months. Complete antibiotic coverage was defined as prescription of antibiotics with predicted activity against all CF-related bacteria detected. Otherwise, we classified it as partial. And then late antibiotic coverage was defined as the addition on or after 48 hours of an antibiotic that would cover a particular CF-related bacteria. For statistical methods, the unit of analysis was the study PECs, and patients were allowed to contribute multiple exacerbations. For each of the specific CF-related bacteria of interest, we ran a separate generalized estimating equation model where we modeled complete versus partial coverage. And then we regressed that on demographic and clinical variables of interest. And then also we used, for visually displaying the data, intersection plots and forest plots. So our study population, we had about 4,900 children with 28,000 exacerbations that met our study inclusion criteria. 73% of these exacerbations had polymicrobial infections. The remaining 25% had one infection, and then we had 2% with no infection. The median age was 15 years. Our median baseline FEV was 74%, and this cohort was majority white, non-Hispanic. So this is an intersection plot. So each bar that you see is a particular combination of bacteria, and then it goes from most commonly found combination to least common, where here we can see the most common are Pseudomonas occurring with MRSA, and then Pseudomonas occurring with MSSA. And then you can see, like on the far right, less common but is occurring, we see Burkholderia with MSSA. We did find a hierarchy in antibiotic coverage, with Pseudomonas having the highest coverage at 98%. And we see this funnel down effect where for Stenotrophomonas and Achromobacter, it's between almost like 50 to 70% coverage. We're also seeing variation by phys hospital. So each bar here is a separate phys hospital, and on the y-axis is proportion of exacerbations that had complete antibiotic coverage. And it really varies from about 80% to almost 45%. So this is a snapshot of some of the modeling results. I'm just showing it for MRSA and MSSA here. And to orient you, these are odds ratios with 95% confidence intervals, and all of the labels on the left, those are the clinical and demographic variables that went into the model. We are finding, so if Pseudomonas was detected in the cultures in the 12 prior months, we're finding that you were significantly less likely to have complete coverage for MRSA and MSSA in the current study exacerbation. We're finding that if you had MRSA detected in the prior 12 months, you're much more likely to have complete coverage for MSSA in the current PECs, and then we're seeing the flip. So if you had MSSA detected, you're less likely to have complete coverage for MRSA in the current one. And on the bottom here, another thing we looked at is we're wondering if the past predicts your current scenario. So if for those that had a prior study PECs, we looked at what were the CF-related bacteria that they had, and did they have complete coverage or just partial? And we are finding so that if they had the same organisms, complete coverage, they were much more likely to have complete coverage again. And then we're also finding the flips. If they only had partial coverage, that does tend to seem to happen again. And then we did run some sensitivity analyses where we found similar results. So that's where we selected one study PECs per patient, because some patients are contributing many more than others in the model. And then also looking at respiratory cultures in the 6 months rather than 12 months prior. Here's a forest plot looking at a selection of the model results for each model. So the MRSA and MSSA are what we've already seen in the prior slide, and then it goes all the way through Burkholderia. One thing to note, this pattern of having complete coverage for the same organisms in a prior PECs does seem to follow through with every single CF-related bacteria that we're looking at. Interestingly, we also find if you had different organisms with complete coverage in the prior, though not always significant, we're seeing a pattern, that you're more likely to have complete coverage that carries through. And then other patterns were found in the modeling, but were not always consistent. In particular, we were interested in the census region. We thought we maybe see a neat pattern. Not necessarily true, so we weren't able to make strong conclusions there. Looking at late coverage, if we have certain, these are the top 10 combinations of polymicrobial infections. Late coverage for Pseudomonas, super rare. More common for Stenotrophomonas and H. flu. So in conclusion, more than 70% of exacerbations had polymicrobial infections, and one of the strongest associations with complete coverage was having that prior PECs with complete coverage for the same infection. And a majority of all of the exacerbations with polymicrobial infections had complete coverage. We found that there was that kind of hierarchy of CF-related bacterium. So if you had Pseudomonas, you were likely to have coverage for that. And then it's opposite for Achromobacter with 53% coverage. Providers may be attributing greater importance to certain bacterial species and to target individual CF-related bacteria in the order of some priority, such as perceived pathogenicity or contribution to that exacerbation. Though our CFF patient registry FIS linked database does not collect data on the prescriber rationale for complete versus partial coverage, and it's likely that the initial antibiotic choice is based on part on what worked in the past. as well as provider preferences or beliefs on the optimal antibiotic approach. And so we would love to do a future prospective observational study where we could more accurately ascertain the reasons for what's prescribed and why, and maybe like a mixed model approach where maybe we can have like a qualitative part. And then finally, to acknowledge my study team. John Cogan has been my mentor, has helped me through the years. We've done numerous studies. This is kind of like our finale one, I feel like, with the grant. And of course, Ron Gibson, Luke Hoffman, Boots, Dave Nichols, and Margaret Rosenfeld. Wonderful to work with. Thank you all. Matt Hall, shout out, because he answers all my strange emails about the FIS database. And then, of course, the CFF and the patient registry for allowing us to use the data. This wouldn't happen without that data set. And then you can find me at poster number 119.
Thanks, Anna, for that talk. Does anyone have any questions? Go ahead.
Do you all have any collected data on allergies of the patients? Because if they have one or more antibiotic allergies, that's also likely.
Right. Unfortunately, we don't have a good capture of that. And if we did, it'd be coming from the patient registry. But that's a good point.
I was wondering, Anna, if there's any way to go back and, I guess, is complete coverage the desired intervention? Like, meaning, is the clinical response better, like with FEV1?
That we would love to look at, I think, for like a prospective study. We chose to not look at those for this because we knew that there was going to be differences in disease severity. But that is a really good question, and I'm learning from my colleagues that we don't necessarily want to treat all of the things at once. So that's a good question.
And it brings up kind of, the study brought up for me, like, how far do we go back with our cultures? Like, that's a good clinical question. Like, if they have 4 available that year, how far do you go back to treat?
Yes, so we published a study recently looking at, for Pseudomonas, we're finding that people seem to be treating it even 3 years after the last positive culture. So there's a bit of that going on as well.
I have a question just relating to the definition of how you defined polymicrobial infection and the number of sputum samples in the 12-month period. Did you pool all the samples together, or was it polymicrobial infection per sputum sample?
We pulled them all together in the prior 12 months, so anything and everything, and it was from the CF registry.
Any other questions? Thank you so much, Anna.
Great, thank you.
Thanks. So we move on to our final speaker, Don B. Sanders, who's Associate Professor of Pediatrics at Indiana University School of Medicine. And his title will be The Stop Peds Study of Oral Antibiotic Timing in Pediatric CF Pulmonary Exacerbations.
Well, thank you for the invitation to speak here today. And I'll be speaking on behalf of the Stop Peds study group. My only disclosure is support from the CF Foundation. You've heard a lot about pulmonary exacerbations already today, so I'm going to go through sort of the motivation for this study. And really, there's a lot of interest in optimizing treatment of pulmonary exacerbations. So in a survey of people with CF, 3 of the top 10 research priorities were related to pulmonary exacerbation, including simplifying treatment burden, antibiotic choices, and as well as reducing antibiotic risks, including resistance and adverse drug effects. Edith Zemanek from our group published or presented at NACFC the last time we were in person a survey of parents of children with CF from the Community Voice group on pulmonary exacerbation-related questions and their importance. And so this group told us that avoiding antibiotic overuse was important or very important to nearly all of the parents surveyed, and as well as the impacts of outpatient exacerbation and lung disease progression were also important or very important. So these two important questions sort of are telling this balance we need to strike. We don't want to overdo antibiotics, but we don't want to risk progression of lung disease if we're not treating appropriately. And so the question for us is, are we striking the right balance? If we look at children without CF who have viral illnesses, 40% cough for at least 10 days or more with their viral illnesses, and I was taught and in my practice, let us know within a few days and we'll start antibiotics well before that 10 days is up. In a randomized controlled trial of children with non-CF bronchiectasis that had a placebo arm, symptoms of an exacerbation resolved by day 14 in that placebo arm in 43% of those participants. So nearly half didn't require antibiotics to have symptoms resolve. If we could simplify exacerbation management and avoid some antibiotics, we could really reduce the exposure to antibiotics to our children with CF. Prior to modulators, we reported at Indiana University and University of Colorado that 75% of school-age children with CF received at least one course of oral antibiotics each year. So we designed the Stop Peds pilot study to determine the feasibility of answering some of these questions. So this is really a pilot study evaluating the feasibility and acceptability of randomized antibiotic timing within the first 7 days of symptom onset, exacerbation symptom onset. So we had 2 arms in our study. With the immediate oral antibiotics arm. So when we found out about these symptoms, we initiated antibiotics as well as recommended more frequent airway clearance. And then we had the tailored therapy arm where we just recommended more frequent airway clearance alone at the time of randomization. And then we could add oral antibiotics later for worsening cough, cough that was not improving, and cough that was not resolving. And I will say that these guidelines were built for this study as sort of a guardrail. They were developed with parents of children with CF. We had our own family advisory boards. We had clinicians with CF, really to make sure people felt comfortable being in the study. Our primary objective was to determine if this was feasible and then determine if we could avoid antibiotics in the tailored therapy group. So some of our key eligibility criteria, so children with CF had to be between the ages of 6 and 18. Their baseline lung function had to be above 50% predicted, and they had to have had received at least one course of oral antibiotics for an exacerbation after January 1st, 2019, so about within the year or two prior to enrollment. We excluded children who were recently treated for antibiotics for an exacerbation at the time of enrollment, although they could come back later and enroll. We excluded those who were on chronic oral antibiotics other than azithromycin, chronic steroids, and those who had solid organ transplantation. Once randomized, we developed additional criteria for providing additional therapy. Again, these were created in conjunction with clinicians and parents of children with CF. So if cough was worsening, again, if it was stable but not improving after a week, if cough was improving but hadn't resolved by 2 weeks, and if at any time they developed shortness of breath, impacting their usual activity. So if they're out playing soccer and they're a little more short of breath, that was an indication. But if just going upstairs was more of a problem, then that could occur. If that occurred during the randomization period, we would add antibiotics if they had not yet already been started. And then if they're already on their antibiotics, we would return them to their clinical team for additional management. And at any time, parents or families could say, we want to go back to clinical care. So it wasn't just holding their feet to the fire on these criteria. So the overall design of Stop Peds was that we enrolled children at their baseline, and then we followed them until we heard about respiratory symptoms. And we sent them weekly text reminders that just said, have you had any new respiratory symptoms in the past week? When we heard about new respiratory symptoms between 1 and 7 days, whether that was via the text message, phone call, or a clinic visit, we evaluated them for randomization. And if they were too sick, then they were excluded from randomization at that time. The criteria are there for who was too sick to be randomized. Once they had recovered and completed their treatment, they could be assessed at a future event after 28 days had passed. If symptoms were acceptable for randomization, then they were randomized to the 2 treatment arms I mentioned, the tailored therapy group, the immediate antibiotic group. They were then followed for 28 days remotely with some surveys and phone calls, and then we had a final study visit at day 28. And all of these arrows here were important feasibility metrics that we wanted to know about with this study. Could we enroll at baseline? Could we hear about symptoms? Could we hear about symptoms early on? How often were some participants going to be too sick to be included? If there were acceptable symptoms, could we randomize them? And then would participants return for a study visit 28 days later? So we enrolled at 10 sites between November 2020 and December 2021. We approached 213 children with CF, and we enrolled 121, which was our goal. Pretty evenly distributed between the two age groups by sex. Race was representative of our centers. We did have materials translated into Spanish. We started this study before Trikafta was approved down to age 6, so about 2/3 of our participants were on ivacaftor or Trikafta at the start or at enrollment. That went up later. The baseline FEV1 at the time of enrollment was 97.8% predicted, so a pretty healthy cohort. Also, consistent with pediatric cohorts, MSSA staph was the most common, with a minority of participants having MRSA or Pseudomonas in the year prior to enrollment. So I'll walk through the feasibility outcomes first. So 94 of our 121 participants reported to us at least one exacerbation. So that was nearly 80%, and I think in line with what we were expecting to see. Of those 94, 81 eventually told us about at least one exacerbation that met randomization criteria. Of those 13 participants, 13 reported to us exacerbations that were too severe for randomization. Within that group, there were 4 symptoms that we found out about after 7 days. From those 81 who met randomization criteria, one more point. The mean time to the first report of the eligible symptoms was about 3 months, with a wide range in reporting. Of the 81 that met randomization criteria, 63 were ultimately randomized. So again, about 80% of what we heard about that we could randomize, we were able to randomize. These were some of the most common reasons exacerbations were not randomized, even when they met criteria. So number one was there's discomfort with randomization, and I will note that this occurred in both arms. I can't say if it was equal or not, but some didn't want to be on antibiotics right away, some wanted to be on antibiotics right away. 10 participants thought cough was related to other causes. So in other words, they thought there was a cough but not an exacerbation, whether it was sinuses or allergies or medication. There was 5 who reported this as poor timing in relation to other life events. 4, the cough had improved or resolved by the time we came back to them with the randomization. And then 3 were not randomized because of physician decision. 63 of the 63 exacerbations of symptoms that were randomized, 60 occurred remotely. So we heard about them via text or via phone calls. And again, this was during the pandemic, so a lot of us were doing a lot of remote. So this, I think, reflected our practice. And also, outside the pandemic, most of our exacerbations in kids being found out about over the phone. So after we randomized 63, and in consultation with the Data Safety Monitoring Committee, we stopped the study. We thought we had met our feasibility goals. We understood what was going on, and we were having lower rates of exacerbation, as most of us were across the U.S. So of the 63 that were randomized, 30 went into the immediate antibiotic arm, and 33 went into the tailored therapy arm. Of the immediate antibiotic arm, 29 received antibiotics within 28 days, so there was a delay in one participant receiving their prescription. By that time, they felt better and didn't want to take the antibiotics. In their tailored therapy arm, of the 33 that were randomized, only 10 received antibiotics within 28 days, so we were able to avoid antibiotics in 70% of those participants. We'd say had some additional clinical outcomes that we tracked. So in terms of returning to clinical care, 43% in the immediate antibiotic arm and 27% in the tailored therapy arm returned to their clinical teams. I will note that in the tailored therapy arm, we could add antibiotics before returning them to clinical care. So while there were more in the immediate antibiotic arm, we had more flexibility in the tailored therapy arm to not return them to clinical care. All the participants, even those who returned to clinical care, were followed closely for 28 days. Only 7 participants completed an in-person visit at day 28 and had spirometry. So the remote nature of this study was really favored, and like many of us at the time of this study, we're doing a lot more remote telehealth visits. So we don't have spirometry data. Only 1 participant was hospitalized during the study. That was a participant in the tailored therapy arm. This occurred 20 days after randomization. It was attributed to a new respiratory virus and thought to be unrelated to the treatment assignment. We have some data on symptom recovery. On the left, we have the CRIS scores, which you've heard about today in the 12 to 18-year-olds. On the right is a similar score I'll get into. But I want to start with the big caveat here that we have very small numbers. The immediate antibiotic arm in pink and the Taylor therapy arm in blue have these very wide 95% confidence intervals, these shaded areas. So we were just making sure we weren't seeing something obvious here in terms of symptom severity. So the CRIS score, we had 5 or 6 measurements in the well state at baseline, and then we see the CRIS score get worse and go up at the time of exacerbation, and then start to come back down, and on average, participants have returned to their baseline around by day 10. And then at day 28, we're still right at their baseline. We had a modified CRIS CFRSD scoring system for the 6 to 11-year-olds, so we simplified it a little bit and used some smiling and unhappy faces. And then we scored that and scaled that to 100. This is not a validated score, but we're just trying to get a sense. You can see in these children, their symptom score went up at the time that they transitioned from the well state to the exacerbation period. Then they came back down. Looks like there's less variability overall, and participants were on average at their baseline at day 28. In terms of adverse events, there was really not a difference in severity and study relatedness between the two arms. There were no life-threatening AEs, and none were definitely study-related. Overall, 11 participants in the immediate antibiotic arm, 37% had 21 events. In the Taylor therapy arm, 8 participants, or 24%, had 10 events. There's only one probably related to study intervention. There was maybe a little bit higher rate of diarrhea in the immediate antibiotic arm where there was more antibiotic exposure, but low rates overall. So from this study, we would conclude that randomization of outpatient pulmonary exacerbation management in school-aged children with CF is feasible. Managing a single mild exacerbation in school-aged children with CF with a Taylor therapy approach can avoid oral antibiotics, and for us that was in 70%. But further study is necessary to determine if this is safe and effective for repeated exacerbations over time. I also note that this did not enroll the younger children, less than age 6, who are going to be exposed to their viruses even more frequently than our cohort was. I want to acknowledge everybody at the Stop Peds sites, including our investigators and research coordinators, especially Sharon McNamara and Lisa Bendy, who are our research coordinator leads for this study, and the rest of our team, including Margaret Rosenfeld, my co-PI, the CHSCC, who ran the study, the CF Foundation, and their community voice, our advisory board, and then all of our participants and families. And I'm happy to take any questions.
Thank you very much, John. Do we have any questions?
In your conclusion, you said you avoided antibiotics in 70% of the patients, but you didn't include the 30 you treated with immediate antibiotics. So you don't know how many was avoided if those patients had a Taylor therapy?
Correct. In the approach where we had tried a Taylor therapy, we were able to avoid 70% in those. But yes, we had another arm that we did supply antibiotics to. So yeah, it was 70% within that arm, not the overall cohort.
All right. We have a question there at the back.
With your patients that were in the non-antibiotic arm, did you still have them increase treatments during their exacerbation like we typically would?
Yes, we were trying to mirror our typical practice, and we try to provide the same instructions to both groups about increasing the frequency of airway clearance. Yeah.
Bill Farrell, Wisconsin. During the interval of the study, wasn't it a period of particularly low respiratory virus exposures? And that could be a limitation regarding conclusions?
Yeah, exactly. So the question was, since we did the study when there were no viruses around, does that affect our conclusions? And certainly, I mean, I think if we were enrolling today, I think we would have no problems of finding exacerbations. And I think that, the virus question is an important one. I kind of wish we had, never mind, I'm not going to say that. So I think there are some really good questions that we'd like to address in a future studies. Yeah, and virus is an important one.
We have a question there.
Yeah, I mean, I think in terms of the first question, we were pretty limited in our ability to look at subgroup analyses. I mean, I think if we wanted to look at the Pseudomonas, we would have 2 or 3 in each group, the targeted therapy arm and the immediate antibiotic arm. So we're not really able to make conclusions based on the microbiology. In terms of convincing families, I mean, I think, we're seeing this question is, are we overusing antibiotics? Are we underusing antibiotics? And from this, we would say, well, we watched people very closely for a month. We didn't see, we saw symptoms return. We didn't have lung function data, and maybe we should say the antibiotics later, when maybe we need them more. So, we have seen that, we have worked very closely with families throughout this, and we've seen the gamut. I would never be able to avoid antibiotics. I'm so excited I could avoid antibiotics, and so it's really, I think, part of the step, though, is making sure that this is safe and effective, and did we include the right severity of exacerbations? And so I think we just have additional steps to really not only convince our families, but ourselves as well. Yeah.
I think there was a question there.
At the time, we had about 2/3 that started, and then throughout the study, additional came on when the approval in the U.S. came down to age 6. And thinking I think at the time of randomization, the cohort was very similarly balanced between the 2 groups. But that was the motivation for us, was now that we have this, do we need to treat people the same way? I think the use of Trikafta, I think, probably impacted clinicians. In terms of families, I feel like when we said, we would like to do this for 1 mild exacerbation, that seemed to be the case. I don't think we necessarily over-enrolled children who are already on Trikafta compared to the rest of our center, but I'm not sure that we specifically asked that question. Yeah. So that's a good question. So the question is, when we said we would give you antibiotics if you were still coughing at day 14, that was our guideline. That was something we wanted to have in there so no one was worried our kids would be in that state and they'd be coughing and we would never know about it. So it really was, we wanted them to be back, for the most part, back to no cough. Now, I don't know how often when we said, okay, you're at the day 14 mark. For most, I don't think they were still coughing there. I don't know if when they reached that point, they actually received the antibiotics they received or not. That became more of a discussion with the clinical team, especially if they had been started antibiotics already.
Don, I have a question. One of your slides, you said your approach 213, but there were only 121 participants. How do you account for the halving of the people who were not included? What happened with them?
That's a good question. Honestly, part of it was the pandemic. We had required an FEV1 measurement. Some of them didn't have a recent FEV1 measurement. We had required initially a more stringent oral antibiotic frequency.
So it wasn't parents declining?
I don't have the numbers for you, but some of it was that we were facing limits we weren't expecting with the pandemic. But I think there were some families, like I said, who, me and my clinician, we're going to make the decision together, and we didn't want to participate. But I don't have the breakdown for that. Yeah.
There was a question at the back.
He was first.
We are sort of back to we're back to our pre-pandemic monitoring. I think we that's sort of a telehealth question, but I think I felt like the strength of one of our studies is that we were hearing about things outside of clinic, which is where we're doing most of our treatment on the pediatric side. So we really kind of wanted to hear about these symptoms early and mirror that. And I think when we were planning this study, it was right at the beginning of the pandemic, and we were just trying to answer all those questions then. And now, 2 years later, how could we do things differently? But yeah, I think since we're always going to be getting phone calls and trying to decide what to do, I think this still is going to have some applicability for us, yeah.
I think we'll take one more question and give time a break.
My question was similar to that one, is that, didn't really focus on FEV1, baseline FEV1, and, kids getting back to their baseline, and this really focused on the kids, right? They're subjective, the patient's subjective, and parents, subjective symptoms. Do you think that that's like where we're going, or, it's true, I think related to the pandemic, like, we can't get people to come in as often, or, is it not enough? That's my question.
Yeah, so I think just, we were asking about the CRIS, but we weren't looking at that data in real time. We were just asking about cough and your symptoms and how you're feeling. So this was very much symptom-based, and I think that is a very important question. And I'm on a poster here that looks at small FEV1 declines and treatment improving outcomes, and so where's the overlap and where's the complementary? So if we hear about early symptoms and we increase airway clearance, do we avoid those small FEV1 declines that show up in clinic 3 months later when I knew I was coming and I've been coughing for a while? So I think that there are questions in both areas that we still have to sort out. But I think also, thankfully, with Trikafta, I think we are seeing fewer of those declines in clinics. So, but we're still going to have these respiratory viral symptoms and other symptoms. So.
All right, thank you, Don. I think that this is a really important topic, and more as young children are started on modulators, and we look forward to future work in this area. Thank you, everyone.
Thank you so much.